So good afternoon, everybody at PCR Online. I have with me Professor Anna Sonia Petronio. She is an expert interventional cardiologist, and she will give us her take on the POPULAR TAVI trial that was recently presented at the ESC Congress. Good afternoon, Professor.
Good afternoon to you.
So if we can take a little bit of your time to discuss what are the differences between the Cohort A and the Cohort B of the POPULAR TAVI?
Well, the Cohort B was published a few months ago, and it was considering patients that needed a therapy with anticoagulation. And the trial wanted to compare the oral anticoagulation against the oral anticoagulation plus aspirin. And they were able to demonstrate that the oral anticoagulation has less significant bleedings and has all, let's say, non-inferiority and superiority for the endpoints of the trial. For the Cohort A, it was a similar comparison in the way that it was tended to simplify the therapy, and this time in patients that didn't need anticoagulation. And it was comparing the simple antiplatelet drug with aspirin, a single one, against the dual antiplatelet therapy that was aspirin plus clopidogrel. The primary endpoints were similar, of course, to the Cohort B, and was all bleedings and non-procedural bleedings, while the secondary endpoints were a compositive endpoint of death, of myocardial infarction and post-procedural bleedings. And the secondary endpoint was instead all the ischemic complication, and that was, of course, myocardial infarction, was ischemic stroke and death. Now, this cohort showed the same positive significance as with Cohort B for the single anticoagulant. So the single antiplatelet therapy had high significant reduction in bleeding. For what concerns the secondary endpoints, we saw a superiority of the composite endpoint where non-procedural bleeding were considered, but instead it reached only the non-inferiority with the ischemic events, meaning that aspirin as dual antiaspirin doesn't have more or less incidence. They had the same number of events. In some way, together with the Cohort R, it simplifies the therapy of TAVI in some way. And it's very nice to see that now we have, in some way, for, let's say, the 70%, 80% of patients, we have now a simple and controlled therapy to do. The problem is that while we will go forwards in our experience as we are now, probably this therapy will not fit all.
Absolutely. So one of the questions that kept coming up during the ESC Congress was about the subclinical leaflet thrombosis, which is often diagnosed with imaging, and there was no imaging as part of this trial design. So do you think we are in need of a randomized trial that looks at an abbreviated antiplatelet course or single antiplatelet course in TAVR with imaging to detect leaflet thrombosis?
Well, certainly this kind of trial didn't answer this question. The contrary, Galileo did, because Galileo had sub-study done on purpose for this investigation, while Popular TAVI didn't expect some four-dimensional CTs post-procedural. I think that we need both things. In some way, we still need to really understand how much is the impact of the thickening of leaflets with the real clinical event of patients. This is one point. Then, of course, we can expect to investigate what the single antiplatelet does. But certainly what Galileo told us is that if people have not only 1 degree thickness, but the increase of gradient in the valve, then anticoagulation needs to be done, because it's, at least from now, it's the only therapy that is able to reduce the gradient and in some way cancel the effect of thrombosis.
So as you mentioned just a few moments ago, there are some patients that may, for example, about up to 20% of them may develop new atrial fibrillation down the line. Young patients may develop coronary disease requiring PCI down the line. So, are we going to be seeing more crossovers and more patients requiring more than a single antiplatelet? And do you expect more of this kind of a crossover down the line?
Well, this is a good question, because as I said at the beginning, with this trial, I think that we are able to cover the 70%. Because, of course, I think all the centers that perform TAVI have at least 50% of patients that really would need only a single therapy, antiplatelet therapy, because they are simple patients. And the more we will increase younger and low-risk patients, the more we will have this kind of patient. But we already saw in the Popular TAVI that we had around 20-25% of patients shifting, or really not really shifting, because we don't know how in the end they were treated. If they were treated with anticoagulation only, or if anticoagulation was added to the single antiplatelet drug. So this is one point. And probably to these people, we should have another population, because getting with treating younger patients, we will perform more PCI in these patients, because we won't need other, stenosis as we do in 85 years old patients. So probably we will, as I told you, we will still have to adjust our therapy for at least a 30% of these patients.
And just a short question here. I know there are a lot of discussions ongoing about what the appropriate regimen for valve and valve, or even if the trials pan out for bicuspid. Do you think single antiplatelet, in your opinion, would suffice?
Well, again here, we really don't know. We know that these kind of TAVIs are more complicated and have left more bulky tissue around the valve. We've got the old surgical valve that is there. We've got a lot of heavy calcified cuffs around, and certainly the flow is not laminar. The risk of thrombosis is higher. So those could be, again, a little bit of a piece of cake that is left out of this kind of therapy. But nothing has been proven until now about that. It is only an empiric judgment.
And currently in the market, we have several different platforms of transcatheter heart valves. So do you think for low bleeding risk patients, we can apply this single antiplatelet regimen for any valve, whether it's self-expanding or balloon expandable, or is this not answered really by Popular TAVI?
Well, the trial with Popular TAVI was done with more than one kind of valve. The main population was treated with both balloon and self-expandable, say that in some way nobody told us that there was a difference. So at least this has not been analyzed. And the patient wore a mixture of these valves that are the ones that are more used in the world.
Well, and finally, when we look at this population that end up with TAVI, we know that they also are bleeding risk. And for coronary interventions, we calculate a has-bled score or a bleeding score for these patients. So do you think the same conclusion can apply if we're talking about different antiplatelets? So if we're not talking about aspirin alone, if we're talking about clopidogrel alone, for example, do you think this can be generalized to all antiplatelets as well?
Well, let's say that aspirin is the one that has been more tested and it's the one that has been more used because sometimes patients need aspirin for other reasons, like cerebral vascular problems, carotid, peripheral artery disease. So I would say that the aspirin is the one that at the end is more used and more tried. It is not something that we are not allowed to say that clopidogrel would not work, but it's not been tested as much.
Thank you very much for your time. Is there anything else you'd like to add about the POPULAR trial?
Well, anything. I think it is a very well thought out and well investigated trial, and it was a spontaneous trial, and this is another advantage of these trials. So I would say that the investigator did a very good work, and it will help us certainly, at least for the next year, we have something with which we can challenge and discuss.
Thank you very much.
Thanks to you.